episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm Jonathan, guy. We have had all cast this last couple of weeks, Wes. It has been a lot of fun to have some real high-level folks on, and today is no exception. We have got a high-level person on as well, and let's bring her on, Rebecca Bockow.
Super excited to bring Rebecca Bockow. Thank you so much for joining the live stream, Rebecca.
Yeah, how you doing?
Great. Super excited to be here. Thank you, guys.
Yeah, absolutely. Tell us a little bit about for those who don't know who you are, and you've got some pretty interesting training and background. Tell people a little bit about who you are, kind of what your training is, and what you do at Spear and in your practice.
Sure. Well, like many of you, I started sort of then was a true CE junkie. So after 2 years going to every I could, I decided to go back and school. I really had to learn as much as I could. So I did a combined peri-ortho program and to Seattle, and have been lucky enough to live out my dream, seeing kids and adults. I see a lot of interdisciplinary cases. We do your regular ortho, and then just a lot of kid stuff, especially as it relates to airway, skeletal growth and development. We do a lot of surgical cases, and I'm lucky enough that I get to work with amazing restorative dentists like Greg Kinzer, and that's how I got involved at Spear Education, which has been just an incredible privilege to be a part of the forward thinking, the vision of that company and what they're doing for dental education today.
That kind of gets into the first question. You've been at Spear for a couple of years now, and you know, when we first dove into the Spear continuum of workshops and seminars, you know, there was a little bit of orthodontics in there. In fact, John and I feel like that we have referred and started more orthodontic cases because of Spear's treatment planning, systems. And how is having an orthodontist on faculty there with airway experience really changed the way that seminars and workshops are being taught right now?
Well, I hope that what we'll start to see, and this hopefully will filter down through the curriculum, is we'll see more and more interdisciplinary treatment planning. There's so much that the orthodontist can do on the interdisciplinary team as far as helping out things like deep bites and open bites and leveling gingival margins, extrusion, helping make dentistry more conservative by moving the tooth instead of cutting the tooth. So there's a huge place for treatment planning. And so I hope that myself and ideas like those that I can bring will continue the curriculum. Now
you're involved.
That we're...
Oh, go ahead.
Go ahead.
Well, I was going to say, so you're involved teaching now in some of the workshops and seminars that didn't used to be orthodontically focused. You're now involved in teaching some of those. Tell us about like how that's changing just the way that some of these seminars and things like facially generated treatment planning, and how is that? I mean, there's been a whole different focus, especially with the airway piece over the last few years. And what are you teaching in some of these kind of more introductory seminars and things? How are you kind of integrating into some of those?
Well, we're pretty excited. We're going to launch our very first truly interdisciplinary seminar. We're doing at the end of this month, and it's one of the most exciting projects I think I've ever been involved in. So the first day is going to be myself and Dr. Michael Gunson talking about skeletal growth patterns. Airway will come up, of course, because we'll be talking about how airway and airway related issues change the way that a face grows. And I have the honor and privilege of being able to talk about a growing child. And then if you've ever had a chance to hear Michael Gunson, he's an absolute genius, talking about surgical options, hopefully talking about joints and occlusion, and airway and facial aesthetics. And then the second day is going to be Greg Kinzer and Jim Janikiewski, two of the best, talking about interdisciplinary more related to the teeth. And a lot of ortho cases, I think, will also come up in that, talking about leveling gingival margins, extrusion, creating space for ideally positioned teeth, or ideal ratios, I guess, of teeth. So for example, if you have a peg lateral, trying to create that ideal space. And so I think ortho is going to play a bigger part in the curriculum, and it's really exciting to be a part of it.
Yeah, I mean, we're excited because we've always had, in all of the training we've had out there, there's always been an orthodontic focus, and there's been cases that get shown. Like we'll see a case where, Greg will go through, okay, so then we did ortho, and these were some of our goals, and these were, in fact, some of the ortho I think was being done by you. And I remember him saying, like when we were in Warren Dentition, he would say, and then, Becca Bockow took over and did this, this, and this. And then it was like a start and a finished picture, but there wasn't that person there to kind of connect that, where you could understand the mechanics of that, the decision making behind it, and also too, you kind of what it takes to be able to pull off this from just a mechanics standpoint. And I think now this is going to be kind of that behind the scenes now becomes kind of the forefront of what what kind of discussions you're having with patients and with general practitioners and with surgeons and with periodontists, because these types of cases that you're treating are, some of them are straightforward and simple, but some of them require this same amount of knowledge that you would need to be able to treat a Warren Dentition case using transitional bonding and going through multiple steps of restorative and periodontal surgery. These are orthodontic cases and airway situations that have a lot of the same steps. So that's one of the seminars that we took before, but we need to come back and take again, essentially, with kind of this whole new. In fact, we want to bring our whole group out and take that again, because I feel like it's going to be, especially for orthodontists. I mean, talk about that. Like, have you seen more orthodontists coming out to your courses, or kind of how is Spear kind of reaching out to the orthodontic community to try to get them involved more in some of these?
Well, I think
John, we may have lost a little bit of an internet connection there. Rebecca, can you yeah, we can still see you. Give me the answer to that there again.
Can you guys still hear me?
Yep, we're good. Go right ahead.
Yeah, we gotcha.
So I think the goal for this seminar is this will become the course, the seminar that interdisciplinary teams can come to together, so that you can be sitting side by side with your orthodontist, with your surgeon, and say, hey, do you remember that case I showed you last week? Can we make this happen? Or talking about it back in your study club weeks later, hey, this case came in the other day. Is this something we could do and work it up just like what we saw in the seminar? So this will become a place and an avenue and include the orthodontist in the session. There's a lot of orthodontists involved in Spear across the country, and this will help bring them into the interdisciplinary team, bring them into the discussion more.
John, one of the things that I like about what Spear is doing right now, and we're going to get into some nitty-gritty clinical things here just in a second, is that they are reaching out to the specialist and in a big way. And they've been doing that for years with these local study clubs and things like that. And I've been really happy with their progression in including orthodontists. This has really been a big push, and it has really helped me in my practice. And not only from a referral basis, but just an identification, right, of some of the things that we're learning and how to incorporate, right, these new ideas, maybe not new, but these metrics, right? How are we doing our exams? Let's talk a little bit about some basic metrics, Rebecca, that a typical dentist maybe can incorporate into their examination that can help us define really what a normal airway or a good airway versus one that might be at risk or could require treatment. What do you recommend that we look at every single time? And what are some points where we would really try to intervene? Like what points would we say, okay, this is the time, right? And these are the metrics that I'm looking at.
Well, and that answer might be a little different depending on the age group of the patient. So I'll tell you that every pediatric patient, and pediatric meaning 18 and under, is going to fill out a pediatric sleep questionnaire as part of our new patient paperwork. If you guys don't have it, I'm happy to give you a copy so you can post it on your Facebook. It's research-based, published by and number of, there's a high likelihood they're going to have some sort of sleep disordered breathing. In many communities, these patients are not don't have source of access to a pediatric sleep, and so this becomes a great way to identify some of these patients. Once you get the health history, it becomes a real open-ended discussion with the family. There's things that they'll bring up that they never thought to bring up to their dentist, like bedwetting or behavioral issues, or does my child snore? Does my child grind? These things that they never really correlated with something that the dentist would need to know. And so you'll get a good snapshot of whether or not a kid has an issue. Of course, we can look for tonsils, but even just watching the demeanor of a patient. Is a kid sitting there with their mouth open? Do they have bags, circles under their eyes? And then we start to look for some of the big malocclusions. So crossbite, open bite. These are both things that you might see in someone that has a low tongue posture and a mouth breathing habit. We're going to see underbites and overbites, and both of them can be or their growth changes. Many of these things are correlated with tongue ties, so looking for tongue ties. Asking about a history of breastfeeding. Were they able to breastfeed? Asking about speech therapy. These are all things that we never historically asked in dentistry. We didn't know to ask these questions. And then to just sort of dig deeper. For adult patients, they may have already been treated orthodontically, and you can get fooled. You can see a class 1 patient that still has airway issues. And so once again, asking these questions, there are some screening tools like Stop Bang, an Epworth sleepiness scale that can help open your eyes to some issues that maybe the patient hadn't thought to tell you as a dentist. But then, of course, we can look for other signs. And I think Jeff Rouse has given us some great tools to think about when we look at worn dentition. Maybe our worn dentition patients are all airway patients. Looking for those big skeletal discrepancies, underbites, overbites, crossbites. These are all signs that airway is not great. The controversial one is extractions. And so not every case that has had teeth extracted, but if you start asking skeletal, sometimes someone that had teeth taken out potentially have an airway issue. I will say that with a caveat that I don't think extractions cause airways. But if we, and maybe this is not time and place to get into this discussion, but sometimes teeth are taken out instead of dealing with the airway issue at a young age. And so it's a problem that existed long ago that has never been corrected. And so the child that had an airway issue is now the adult that has an airway issue.
I think it is a good time to get into it. I mean, we love to talk about those things that people get kind of fired up about, because I think that's where the real work is getting done right now is in the areas of trying to decide, when do we intervene, and obviously number one is do no harm, right? And we want to know, we want parameters. And I think you can't easily put parameters on that question of when are extractions bad, or you can't just make blanket statements. Obviously it's patient by patient. But what we seem to see in general is that for years, that was just a way that was kind of maybe defaulted. Maybe that's not a fair thing to say, but it maybe in some orthodontic situations was kind of, hey, you've got crowding. We can correct this with extractions. And what do you think? Why do you think this is controversial? Maybe first of all, is this talk about a little bit about that, and then maybe are there some guidelines that you would start to, when you're speaking to your orthodontic colleagues, or maybe just to general dentists who are screening patients in the hygiene chair, as to what to look for that might turn you away from extractions? How about maybe put it in those terms? Why is this controversial, and what would make you go away from that?
Well, I know I'll try and be as diplomatic as I can, but just historically, 30 plus years ago in orthodontics was about how do we get the teeth to fit together, and to fit together in a set of models that we can put on our benchtop. And so if the goal becomes getting the teeth to fit together in that perfect class 1 occlusion, then ideal treatment time becomes, let's wait till all the 12, 13, 14. And then if there's crowding, we extract. If the lower jaw is small, we take out upper bis. If the upper jaw, if this jaw is more prominent and this jaw is small, we take out lower bis, and we somehow squeeze the system together to get it to fit. If the upper jaw is narrow, we tip the lower teeth in. So that used to be how we looked at cases. We know so much more today that we have the opportunity to look at cases differently. But it also depends on what age and what stage in development we catch the patient. So let's take, for example, a 6-year-old or 7-year-old that has a small upper jaw. Let's say they have a mouth breathing habit and they are not sleeping well. What happens when the tongue rests low is you have an underdevelopment of the upper jaw. So that upper jaw is going to be V-shaped, it's going to be narrow, they're going to have subsequent issues with nasal breathing, and they may even start to grow in a vertical direction. Fast forward, if we do nothing to that 6, 7-year-old and we wait till they're 12 or 13, that patient's going to have a ton of crowding and or potentially impacted teeth. And so if we wait, some people might say, well, the only way we can handle that at this point is to take out teeth. But let's back up, and now let's say, okay, we can identify these patients at a younger age. Now we take that 6, 7-year-old and we start expansion. Now we open up nasal passages, we create more space for the tongue, and we simultaneously upright the lower teeth, open by. It's incredible to watch it happen. Kids sleep better. In many instances, the tongue posture changes. If it doesn't, we can work with our myofunctional therapy colleagues. We can pull in ENT. We can look at tongue tie releases. There's a whole host of things we can do as early intervention. So now that 12, 13-year-old comes back to our practice and they don't have crowding. Now we don't need to take out teeth. Mm-hmm. A 13-year-old with airway issues and we expand, sometimes if we waited too long, we still might need to take out teeth, but at least let's get the bone in the right place. So there's different reasons to take out teeth. Sometimes it's for periodontal reasons. Sometimes it's just the system is too small to accommodate the teeth that are there. It's indications for taking, but we have to first, I think, ask, is there an airway issue? The other common thing that we might see in orthodontics is if a patient inherently has a small lower jaw, it's common to take out upper premolars to correct that overbite. But if we ask a different question, especially in a young kid, and we say, why is that lower jaw not growing? Maybe it's tongue tie, maybe it's mouth breathing, maybe it's other issues. And so if we focus our attention more on trying to take away the impediments that are preventing the lower jaw from growing at an early age, maybe we can get that mandible to grow instead of saying, well, let's wait till 12 or 13, take out upper buys.
Mm-hmm.
So it depends on where we catch it, and it depends on our
Yeah.
goals, and it depends on the questions we ask.
Yeah, one of the
you've
things
had-
that you mentioned
go ahead,
there
Wes.
is, you know, and if you're listening to this, we have incorporated that pediatric form in our office. I'll put up on the Dental Guys Facebook page a link to that. We've had that in our office for a couple years, and we'll put that up on the Dental Guys page. I know that's one of the things initially that we changed is like just ask these questions, and if you see so many red flags, then like just raise your hand and ask for help. You can reach out on a Spear forum, and they can help you make some decisions as far as that goes. I think there's this you've mentioned age and teeth as kind of some metrics of when we can intervene and what's possible. I look now at birth to 6 or whenever that first permanent molar comes in as one age and one treatment regimen that, you know, or maybe like we look at a few treatment options in that age. And then you mentioned, you know, post 6 to 12 as one of that next segment of what we can do. And then the 12 plus and even into the adult years, some of the treatment regimens that go in. I think going back, what you're saying is that if we intervene early enough, that we can prevent a lot of problems. And we really feel comfortable now telling or sending patients to our orthodontist or recommending palatal expansion, even in cases, you know, I think that there's some, like there's this hang up, Rebecca, and I want you to speak to this, that if there's no crossbite, we're good, right, at age 6. And now we're using some more advanced things, maybe not they're advanced because it's called a ruler, right? Get out what a dentist does best and measure. And speak to that a little bit, because we can understand some of the medicine about this, and that's a little bit harder. But for a dentist, getting a ruler out and just measuring between the molar width and the upper jaw, and then looking at a few things like that can help you make some good decisions versus just looking at a crossbite.
Right. So there was a great paper published by Miner et al. In the AJODO, which identified a pattern that I'll call bimaxillary convergence, where there's no crossbite, but everything converges. If you have a mouth breather, you have no pressure flowing this way, but you do have pressure from the cheeks coming this way. I'm a mom, I've got 2 kids, and I am guilty as I give them pouches. So you think about the sucking on straws, sucking on pouches. We're doing the exact opposite to the arches by always coming in this way. And so we offer these where there is no crossbite, but and so you can measure, you can take a CBCT, you can even just listen at symptoms. Everything narrow to you, and you see that everything converges in this direction. You can look at the mucogingival junction. In orthodontic, looking at the available bone, everything looks really tipped in. You have room to upright. No harm is going to come from expansion, but a lot of good come from expansion. It's going to open nasal passages. It's going to create. It's going to help gingiva later. It's going to help crowding later. So why not?
Yeah. Right, so that's
I
think
a
pretty big
Wes,
statement, John. Yeah.
Well, Wes said, you know, he made he and I'm just going to say, he kind of said, oh, well, we refer this to our orthodontist, right? Well, okay, so let's quantify that just a little bit here, Wes. There's one orthodontist
and he's listening right now,
within 400 miles of us that actually we can refer to for this. It doesn't mean that all the other orthodontists are bad. It's just that there's only one that's truly kind of dove into this and really has committed themselves to understanding the literature and it kind of expanding into this area, no pun intended, but getting more involved in Airway. And I have a couple of other orthodontists that I can have the discussion with, but there's a lot more in our area, and I think in a lot of areas that are not comfortable, maybe is the best way to put it with that. And I've kind of heard two objections to that. And I don't want to just harp on this the whole time, but I do think it's important to talk about this, because so many people that maybe go out to Spear and they take these courses, then they come back. And this is why I'm so glad you guys are incorporating, trying to encourage you teams to come out and have this discussion, because it's no different than going to a course as a GP and they're like, whatever, because they haven't heard it. But it's even more so for the specialist, because this is really a fundamental change to your business model in a way. You have to have discussions that you maybe aren't as comfortable having, or you've never had before. And the two objections that I've maybe heard from some of my orthodontic colleagues have been either, number one, that it's the data is more empirical. Okay. So you go, okay, well, sure. If we expand, we know that we do create more room and we do, but is this having enough effect on the long term in order for us to be recommending it widely? That's one, very, I don't know about common, but somewhat common objection. Is there enough data to show cause and effect and interventional effect? So I'd love you to speak to that. And the second one, I think, really is maybe my perception is it's just people don't have these discussions, quote unquote. And in fact, it takes a significant amount of time to have these discussions. And of course, Wes and I are believers, and we're doing this, but speak to a little bit about that. What's the data? Talk about intervention and long-term data. What do we have available to us that we can present to an orthodontic colleague and say, hey, not only is this something we should be doing, but there is a cause and effect that we can say in the long run that this is making a difference in outcomes.
Absolutely. There's actually talk about the benefit of expansion as it relates. It's not necessarily in the orthodontic literature. It's in the sleep literature. It's, published a lot. It was and a truer in this field, but it's not necessarily found in dental and orthodontic literature, and that is part of the problem. I think one of the issues, and I do agree with this, is that we have to remember that this is an interdisciplinary approach. And so as orthodontists, we are not claiming to cure sleep apnea diagnosis. We need a sleep physician to make that diagnosis. And in my practice, I work closely with our pediatric sleep physicians and our adult sleep physicians. We work with ENT, we work with myofunctional therapy, and no one's claiming to provide a cure. And I think that's a concern that I think some orthodontists have, is they don't want to run into trouble, for example, or to overpromise when they don't know if they're going to make this life-changing effect. One of the great things is that most of these kids need expansion for dental reasons anyway. And so this comes up a lot in our consultations, is parents will say, well, should we get a sleep study? And I'll say, based on the symptoms you've just presented, a sleep study could be indicated here. I recommend the treatment regardless. If we want a baseline, I 100% recommend it. But you still are going to need this expansion as a cross. We see times we will send them for the sleep study. But just to make the point that you don't just to do these procedures, if there's that much canine impactions, if we're looking at cross bites, open bites, all these things, they're going to require our help anyway.
Yep, that's a good point. Good point. Well, let's talk about adults. We've, as we've taken more courses, and we are, especially when we're getting involved in these interdisciplinary kind of challenging cases in adults where maybe we didn't have good intervention at a young age. And now we're in a situation where, as is taught at Spear, we're trying to decide between, do we resolve, do we control, what strategy are we going to try to take? One of the cases that we run into a lot, and has been a real dilemma for us, has been patients with narrow palates not necessarily but we're trying to decide on how to expand these patients. How to expand when you have crowding, and it's especially a challenge when you have thin tissue phenotypes in these patients. And you want to alleviate the crowding. We're trying to avoid potentially extracting teeth, and there would be periodontal defect issues oftentimes that would be difficult to correct prosthetically if we took teeth out in a lot of these cases. And so we know that there's lots of options, and we talk about, you talk a lot about surgically facilitated orthodontic treatment, in which we would, use bone grafting, tissue grafting, and move teeth. And then there's also options using temporary anchorage devices, TADs, and trying to expand that way. Kind of talk us through how you decide what types of approaches in the adult patient, especially with thin tissue, when you're looking at expansion. What are some of the things that come into that decision making?
Yeah, such a great question, such a great topic. So I used to do a lot of orthodontic treatment plans, but today, with the success we're seeing with TAD expanders, the pendulum in our practice has really shifted, where we're really doing TAD expanders as our first treatment option. We're seeing responses, we're seeing nasal passages open. People report that they're sleeping better, snoring is decreasing. Patients that had a deviated septum are feeling like they can breathe through both sides of their nose again. And we're not seeing the teeth tip out of the bone. And so we're getting these true skeletal changes, and we're getting true improvement in nasal breathing. It's less expensive for the patient than SFOT. And we're seeing a much bigger impact when it comes to airway. So that's really become our workhorse. If the patient has thin periodontal phenotype, and if they get a little bit of recession through the expansion process, we can always come back and do traditional soft tissue grafting that we know is predictable. We have great periodontal colleagues, but that's our number one plan.
Yeah, and I want you to expand a little bit on that. Again, I think no pun intended.
The puns
John,
are just,
how can you not,
they're everywhere.
You can't help
everywhere
today. This whole idea of TAD expansion is fantastic because you did mention that it is a little lower cost than some of these other extensive procedures, and less downtime for the patient. It's not necessarily has to be done in a hospital-based setting. And there are some real advantages to this over some other methods to create more room and more space for the tongue and all those things. And, what are you seeing as far as devices right now? Because there's a couple of different devices. You don't have to get specific, but it seems like that we're really refining this process. It's been around for a while, right? It's not new, but there's some little bit of like, okay, this guy does this guy, this does this, and speak to that, because I know you're a real expert in this area.
Sure. And sort of, so I have colleagues that are strong proponents of a regular design. Personally, what I found, they're to integrate, and so my design. And Juan Moon is a professor of orthodontics down at UCLA. Company find and refine their but there's a number of other options out there. But I like, because he's really the turning appliance. The holes for the TADs are built in the jacks, not onto a traditional expander. It's a hexagonal wrench, a hexagonal appliance that turns it so you can apply a force, and you have to 13 millimeters, because they need to go through the appliance, through the soft tissue, and through both layers of cortical bone. And the idea is so you get bicortical palate, maxillary expansion. There's other designs out there, but that has best for us.
And so you mentioned that, so if you are in these thin tissue phenotype cases, that's kind of become your mainstay. And if you see, because this is something where, again, general dentists, we may not know all the mechanics of those appliances, that's okay. But if you assume that you have these thin tissue patients, you're saying that if you have to graft, that you would often be doing that at the end as opposed to at the beginning of treatment. So I want to maybe talk about why you would choose before or after, because that's something that's come up with our periodontists and our study club, and talking about pros and cons of grafting before and after treatment. What's your thought on that? Why do you say after?
So there's no perfect statement plan. I think that it's a fluid that you have periodont. There are cases where we would thicken the tissue or protect the tissue initially. All know we're going to lose a 0.5 millimeter here and there. So why just fix it all at the end? So I think it's case by case. The other thing we can plan with the patient and our periodontist is if there's an insurance issue, which I know is our patients, maybe we pick a quadrant here and we go for the week before, one during and one after, things like that. If we know that there's not a high scare.
Gotcha. Well, that's definitely something that I think changes the way we think about things, because when we're encountering these cases where we are trying to have that discussion and trying to avoid extraction, we're thinking too, when we think facially generated treatment planning, even before I think there was is developed of an understanding of Airway, just simply looking at things like lip support. Often on these cases, we knew that if we were too aggressive in extractions, we would lose lip support. And so I think these types of cases are so common, and I don't think I really understood, just how to treat these for years. And I think that so let me ask this: when you're talking about those types of cases, because I think everybody wants to understand the protocols for walking through those types of cases. If a team comes out to this seminar, they're going to get some basics on how to have those types of discussions and how to walk through those cases. And there's also some discussion in those seminars, I'm guessing, with Gunson about the orthognathic options too. Is that right?
Yeah, it's going to be a big part of day one. Absolutely. And like you're really great to bring this up. To our patients about orthognathic surgery is really important. Practitioners, if truly that is best option patient, they will listen. And historically, I think in dentistry, of saying, oh well, you used to want surgery, then you. But I'll tell you, surgery is a fantastic option for the right patient. And as I think the effort to have those sessions with our patients is also really great.
I know, Rebecca, you're having a few internet issues there, and that's okay because we can resolve those and get you back on here, in the coming weeks. We've talked about that before the show, and we'll kind of nail out some
everyone in the world is on the internet right now,
right?
And
so,
has nothing better to do. So,
right, so I don't want us to worry about too much about some of this coming through. If you're listening to this, we've got a great relationship with Rebecca Bockow and Spear Education, and we'll work through some of those things. I think that the last thing I want us to do is there's just so much controversy right now. You hear people, behind the scenes even, and that talk about whose responsibility is it to treat the airway issue? And if we can get this last question in, it would be great. In the developing dentition, some say there's not enough data. Some say there is. Is there the need? Like, what would you say if you have a dentist that's kind of listening to this and they're saying, hey, we're an orthodontist. Is this something that I want to incorporate into my practice? Because to me, it's a total mindset change. You talked about at the beginning this to kind of come full circle, is that everything was built in orthodontics to treat to, or the orthodontic training to treat to the class 1 occlusion. And this wait and see mentality and phase 1 and phase 2 orthodontics were only reserved for maybe the severest of cases, or maybe something that was blatantly obvious. But now there's so much more. Is there, that's the question for you, is there enough data to totally disrupt an orthodontist treatment planning progress? And as an orthodontist and as a dentist, where do you go to learn this, right? That's question number 1. And question number 2, is there enough data for disruption in your practice? Because this is a disruptor.
Mm-hmm.
Sure. Well, I you look of it necessarily from journals, and I think that's maybe one of the hearts. I think the orthodontic community, they printed the white paper, which maybe a lot of the orthodontists are saying. That white paper said that orthodontists cannot claim that they can cure sleep apnea. We can play a role in the interdisciplinary management. If we think that a child has only one option, and that's a CPAP, then we're trying to even part of. And so let's work together. Let's work with ENT. Let's work with sleep physician and try to help these kids. There is a lot of data that says it can play a huge role. I think new questions and looking for things in a different way in and of itself is a disruptor. And so I encourage everybody to become more educated, to ask new questions. As far as the best places to learn this all in one place, I think SPEAR is becoming a great place to gather all this information, because what I learn and what I know, you'll have Michael Gunson, who's a wealth of information, Jeff Rouse, and other faculty too, who are just really at the cutting edge of what's coming out in the research. And then we're all practicing in private practice too. So we're living this. We're not on the podium and just giving information. We're saying, this is what I'm doing in my practice every day, and these are the results I'm seeing. And we're going to continue to refine and update that information as we continue to learn. This data is new. The papers we're citing are 2018, 2019 publications. And so it's very common for communities to say, well, they haven't seen the data, or they haven't heard that this is evidence-based. And part of that's because it's still coming.
Mm-hmm. One of the questions, and I have to ask it, right, that came in, all right, from one of our listeners, and it says, will Class 2s will we be doing more surgeries in our Class 2 cases because of this thinking? Well,
I think it comes down to our goals. It comes down to the diagnosis, and that's a great thing that SPEAR is always like. Start with the diagnosis and then come up with the treatment plan. And so to make a blanket statement is not fair. But if you have a patient that's Class 2 and there's an issue with aesthetics, or there's an issue with inability to keep their lips together, or if they have maybe jaw surgery becomes the option for them. If it's a child that's still growing, there's a number of ways that we can address a Class 2, and that's maybe for a bigger another discussion.
It is, and I think it's good, right? Because this is kind of a teaser of what's to come, right?
Yeah. There's a lot more to get into.
I think what you said there,
the adult especially.
Yeah, I think what you said there is great about Class 2s, and it is See, here's what you said. You said that we need to look at it from a holistic approach, right? It's not just one way. And that's what's hard about this is we've kind of been stuck in the one way maybe for a little bit, and now it's time to broaden the scope just a little bit, like open the lens up a little bit and look at this patient a little differently and think about there's other regimens or other treatment options. And you know what's hard about that? It's hard to have a conversation with the patient, right? Because when you start saying, okay, option one, prognosis, right? And we've got to be doctors, right? Option one, here's the prognosis. Option two, here's the prognosis. And option three, here's the prognosis. And then whenever you say, okay, what's the benefits and risk of each of those? And you look the patient in the eye and you say, now, what do you want to do, ma'am, for your child or for your son or as an adult? You look at them and you say, well, what do you want to do? And you're like, and they're like, oh my goodness. So you see, it takes time. That's why it's
well, and that's a very hard conversation when you start talking about the word surgery, for instance. That's what keeps a lot of people the same. That keeps a lot of people from presenting a $75,000 restorative case. It's just that we're not used to talking about these things. And the first question that you answered is, do we need this? Is this something the patient can benefit from? And especially if it's life-changing, potentially life-saving in some cases, then, I think that we first have to get comfortable with that, get comfortable with the diagnosis side, get comfortable with identifying it, and get comfortable with the fact that there are some real benefits to this. And then it's the second thing is, how do you have the conversations? And that's a whole different ballgame, because you really have to have a team around you that can say the same things that you're saying to your patient. Because if one person, has a dissenting opinion on this, that's just because they don't want to deal with it, then it can derail this whole conversation. Then it can pit one person against another. And so I applaud what you guys are doing, because as you said, a lot of what's out there is new information. And yet you have, a major organization like Spear that's committed to taking that and immediately changing, not immediately, but changing, kind of saw enough proof that it was time to change the way that we're teaching treatment planning from the ground up. And, for Wes and I think we first got into this, honestly, we didn't want people to break our stuff. We were like, well, this is why people are breaking our stuff, because we didn't understand what was going on with Airway. And then the more you get into
I want to know how to build a bite to last a lifetime, right?
I just want to only reconstruct them one time, And
now
that
we're
was
like orthodontists thinking like, man.
Yeah, all of a sudden you start going, oh man, like you can't open Pandora's box and then shut it. You have to be willing to be open to really going back to the very beginning, which is these young patients and understanding start to finish. So, I think it's a change, and it's hard. Wes has made the comment when he really started implementing this hardcore, and he's gone all in. He retired a hygienist and made her a myofunctional therapist, and so, and Wes has said multiple times, this is the hardest thing you've ever implemented in your practice, right, Wes?
Hardest thing ever, man. It is the hardest thing to incorporate, because as a general dentist, you don't just see adults. And if you come back from an appliance course and you just say you're going to make appliances, right, to treat airway, no. Because if you really dive into it, you want to know how to go correct it so they don't end up in an appliance, and they don't have to have surgery, and they don't have to have TAT expansions, dome procedures, and all these things. So you're like going back to the kids, and then you're like, oh no, I need a myofunctional therapist, I need an ENT, I need a sleep physician, I need to just start a study club, and it snowballs into that thing, and it's interesting for sure. Thank you so much for being on the show.
Well, I'll tell you, we're going to be getting you back on the show to get into some more, because I want to talk more about the white paper, and I want to talk more about some adult treatment options that we've kind of said some words like dome procedure and some orthognathic surgery stuff. I think it would be great to get into some nitty gritty and some nuts and bolts on those types of discussions. And I really would love to hear more about how you actually talk to your patients
Yeah, I think
about
it'd be great.
these more invasive and involved options, that because I think we all are looking for the verbiage. Before we kind of let it finish up for today, though, tell people where they can find out more about you, and how they can kind of connect with what you're doing there at Spear, and where, just where can they find out more about what you're up to?
Yeah, thanks. So I tried my Instagram, our Bockow, and my Facebook page. Keep it updated with lectures that I'm doing. You might see some pictures of my kids on there too. And my practice website, Seattle Smile Design, is also updated with the lectures that I'm giving, and then really staying in touch with Spirit, the content that's going to be coming out in the next year. The curriculum that's being built is just so top notch. It's so stellar, and I'm super pumped about it.
Well,
so awesome.
Thank you so much for being on the show. Well, if you're listening to this and you've liked what you've heard, we want to give you more like this, and leave a comment down in the comments section. If you're watching on Spear Education's Facebook or YouTube, leave a comment there. And if you have a question for Rebecca, please leave it. We'll reach out to her, and I'm sure she'd be happy to answer those for you. So if you're listening on the Dental Guys and you haven't given us a 5-star review, right, you need to do that, right? And you can find us on Apple Podcasts. You can find us on YouTube. All of the things, just like Rebecca said, Instagram, all those things. And so, John, any parting words from you, and as you close out the show?
Well, I think that this, I love having access for our listeners to people who are able to talk the talk and walk the walk. When you are looking at how to change your practice and where we need to be going, I think this is definitely where we need to be going. And it's exciting to get to hear, from Greg and talking about these cases, and then get to hear from the person, one of the people that's involved on the other side of it, from the orthodontic side. I'm excited to hear more from Rebecca, because this is, I feel like, an area that for a lot of general dentists is uncharted territory, and it's an area that we need to understand more, so that when we have these discussions with patients, we can know how to talk to them. And when we have these discussions with our specialists and we're trying to develop a team, that we know how to identify people, how to get that education to them and to us together. So I'm just super excited to get to talk more with her about that. We're going to be bringing you more high-level content from people like Rebecca, and we've got another great week planned next week with some awesome guests that are going to be with us. So make sure you stay connected with us and tell us what you thought about the show. For Rebecca, for Wes, I'm John, and this has been another great episode of The Dental Guys.